Thank you very much for allowing me today to present on something that's extremely important, and that is the case for access to expanded carrier screening. I will go through a series of slides. I look forward to the conversation that you'll have in the chat room. So, as has been stated, I'm a professor of obstetrics and gynecology, but also a subspecialist in maternal fetal medicine, and have a background in genetics. I need to show you this disclaimer, which is from Thermo Fisher, and you should read this because it suggests, of course, that the speaker was provided an honorarium through Thermo Fisher, but the parties presenting images, text, and materials represent they have the right to do so. Thank you. My other objectives are you see listed here. And at the conclusion of this presentation, you should be able to experience the evolution of technology, the advances in genetic sequencing. I appreciate the advantages of carrier detection status, the next generation, for a large variety of genes implicated in inheritable genetic disorders. But most importantly, to talk about it from the multi-ethnic perspective. And of course, I'm going to give you some examples at the end, which discuss various conditions. As has been stated, I am the medical director for the Access to Expanded Carrier Screening Coalition. It's always important to start with the beginning. And in the early 1950s, DNA was determined by Watson and Crick to be composed of two polynucleotide chains. And on the right, you can see the primary proteins that make up the genetic DNA code. Why do we want to talk about this? The goal for obstetric care is for the identifications of pregnancies at increased risk for maternal and fetal morbidity and mortality. So it's always important to talk about what the leading cause for infant death is in the United States, and that is birth defects. Now, it may be a little different depending on ethnic groups, but the reality is the constitution of birth defects is the leading cause for infant death. So when we think about these type of things and you look at the crossword puzzle, some of that's related to chromosomal abnormalities, which we certainly do screen for. Some are related to fetal anatomical developmental defects. Some are related to maternal conditions. And of course, a large percentage of them are related to heritable conditions. If you look at the evolution of genetic risk assessment, now we think about how we've evolved chromosomally. Age-related risk was what I was trained on. 80% of Down syndrome births were, however, to women who are less than 35. Even though we use 35 as that magic number, primarily because of the risk of amniocentesis being about 1 out of 200 for pregnancy loss, which really equated to what the risk for was having a baby with aneuploidy at age 35. The evolution went a little further in my early years in multiple marker screenings, where we would look at ultrasound parameters, such as the length of the femur, the polycystic kidneys or dilated kidneys. All of those are heart defects. This multiple marker screening improved our detection rate for Down syndrome. But non-invasive prenatal screening really went a lot further, looking at analytes. And with those analytes in the mother's blood, we were able to detect 99% of infants with Down syndrome, or fetuses. Now let's talk about heritable genetic risk assessment. I'm going to talk about family history. But the reality is, regardless of how good you are at taking a family history, 80% of these disorders have no family history. Hence the creativity for screening. Cystic fibrosis, most effective in Caucasian populations, but we know that multi-ethnicity even changes this with regard to the different types of mutations that there are that make up the cystic fibrosis gene. And then ethnicity-based really varies widely by ethnicity. And we have to always ask the question, what is our ethnicity? And so this is telling you the story behind why family history and even genetic history has its challenges. This is a standard risking tool that I used years ago, and so pardon me because it's part of a slide from one of the early ACOG technical bulletins back in the 80s. It hasn't really changed that much. But it basically is used prenatally and preconceptionally to give you some evidence of what risk might be for a couple. Age 35, and the basic questions are, have you, the baby's father, anyone on either side of the family had any of the following disorders? And you can see what that shows. Did you or the baby's father have birth defects? And I can tell you when I take a history, it's only good as the person who's taken the history. And so we'll give you some perfect examples of that as we go to the end of this. If you or the baby's father, African American, has either of you been screened for sickle cell trait? Very interesting question. Again, this has evolved and gotten better, but it still leaves us a little bit bare when we begin to talk about couples who we don't know, and who in many instances may not be as familiar to answer these questions. The reason I show this slide is because this is the evolution of aneuploidy screening. I grew up in an era of fluorescence in situ hybridization for karyotyping, just so that we could get an answer more quickly as to whether the mother was carrying a fetus with Down syndrome, trisomy 18, or trisomy 21. This was a major breakthrough in genetics. And so when we talk about next generation screening that we're going to talk about more, it is even more revolutionary over the last decade or so. Now, fetal risk assessment is absolutely essential for healthy outcomes. And this is really just kind of giving you a basic review of genetics. There are two main types of genetic risks that impact pregnancy outcome: inherited risk and spontaneous risk. Those are the two things. And technology allows us now to better assess inherited risk by inquiring about family history and also patient ethnicity. But as I said already, family history alone misses many couples who are at risk for inheritable conditions. 80% of children born with genetic diseases have no family history, going back to our slide. And so carrier screening, again, was introduced almost 40 years ago to help identify couples at risk for recessive and X-linked conditions. But we have come so much farther in that 40 years. Simply speaking, when you begin to talk about inheritable genetic disorders, I want you to just remember the mother and father both make a contribution, and simply speaking, if either one of them is a carrier and they pass it on to the next generation, and that carrier has followed the carrier, then we are going to be at risk for having a child with an inheritable disorder. Now, if you look on the right of that slide, there are homozygous presentations, there are heterozygous presentations, there are homozygous mutants, and there are compound heterozygosity issues. And one of the perfect examples of a double mutation is sickle thalassemia, where people are double heterozygotes. We'll talk about that a little bit later if we have time for that. These are the current carrier screening guidelines. And you can see there by the genetics groups and ACOG group, which basically talk about these recommendations. Now, it's pretty well agreed that all ethnicities have cystic fibrosis screening, and also now a spinal muscular atrophy. If you look at Ashkenazi Jewish individuals, there are certain things considered on the panel, but look at all the other conditions that would not be included on a standard current recommendation screen. African Americans, mostly ethnic screening. And cystic fibrosis, as you can see, Asians, thalassemia, Hispanics, really kind of a blank to some degree except for the basic testing, and on and on and on. So hence the concerns that we have about the current recommendations. Let's take it one step further. If we just looked at current carrier screening guidelines, it really introduces some inconsistencies with fetal risk assessment. Cystic fibrosis, 1 in 3,500. Neurotube defects, 1 in 1,000. Down syndrome. Recessive and X-linked conditions, 1 in 300. So I want you to do that comparison. Screening is recommended for cystic fibrosis in every patient. Screening is recommended for every patient with neurotube defects. Screening is recommended for every patient, every pregnancy for Down syndrome. This is the reason that pan-ethnic screening should be acceptable if we look at the risk for recessive and X-linked disorders compared to some of the other things that we routinely screen for. This is, again, an old slide, and it's an old slide for a lot of reasons, because what it shares with us is how evolutionary genetics has been. We've been able to map certain conditions to chromosomes for years. This, for instance, just gives you some parameters with X-linked disorders, and you can see that Duchenne's muscular dystrophy is on the list, et cetera, that have been linked to that. So we've known this for quite a period of time. But it shows you how complex the DNA strand is and the different enzymes the different proteins and how they interplay in those genes. And with the fact that we've now been able to expand the assessment of genes, we are getting more and more information with regard to what we can determine a couple's risk to be. So I want to turn this, as a maternal fetal medicine specialist, I also want to turn this to infant mortality conditions that shorten lifespan. So you can see that if you have screening that's acceptable and even take non-invasive prenatal diagnosis screening that's recommended, you can see that conditions that shorten the lifespan are much more expanded than what we would get for screening recommendations for NIPS. So conditions causing intellectual disability, if you look at expanded carrier screening, you can see the affected pregnancies per 100,000 compared to Down syndrome. And again, I'm only making these comparisons because recessive and X-linked conditions are responsible for nearly as many pregnancies impacted by intellectual disability as one of the most common live-born chromosomal abnormalities called Down syndrome. This takes it even a step further. So what I want to share with you with pan-ethnic screening is that if you look at Northern European populations, we would currently pick up about 24% of identified affected pregnancies, African Americans, and you can see where I'm going with this. If we were to move over to conditions that were at least 1 in 100 in any ethnicity, see how that changes in the third column? And for 176 conditions, see how that changes in the fourth column for different ethnic groups. So identifying affected pregnancies by pan-ethnicity makes sense if we're going to do the best job of identifying individuals at risk. So the limitations of self-reported ethnicity. I live in a world right now where I am in a college campus. There's a lot of mixed ethnicity, and in fact, it is a thing that you check now on the box when you're doing a survey or participating in something or whatever. Assumptions that need to be true for pan-ethnic and ethnicity-based screening to be effective is that ethnicity information is easily obtained, the reported ethnicity is consistently accurate, which we know it's not, and historical ethnicity-based disease risk literature is complete. All of those things are challenging. So the data demonstrates a lot of discrepancy between what the self-reported ethnicity and genetic ethnicity is. You all see the commercials all the time. I thought I was this and I was this with 23andMe. Ethnicity-based carrier screening is recommended, but nearly impossible to execute and be consistently accurate. And there are no recommendations on the management of individuals who self-report blended ethnicity or individuals who are adopted or otherwise uncertain of their ethnicity, which we know more and more is the case. So the impact of ethnicity-based screening recommendations is currently, you could see here, if we were just based African Americans, we do better. For Hispanics, 26% of pregnancies affected by axonal disorders. East Asians, 34%, et cetera, et cetera. So you can see where we are. Now, let's look at where we want to go. We can close this gap if we talk about 1 in 100 in any ethnicity. Look at what happens with African Americans, 96% of affected pregnancies. Hispanics goes to an A, Northern Europeans, 85% goes to a B+, and East Asians goes to an A+. So when we talk about global impact, this becomes a very significant factor for us to take under consideration. I wanted to have you look at this way for a lot of different reasons. Don't worry too much about the colors, except when we look at gene by gene, the approach has resulted in significant gaps in risk assessment. And so if you look at East Asians, which we really are talking primarily about alpha thalassemia, look at the other things that are potentially there. The green bar says this is what we do. The other bars look at what we ought to be doing based on closing those gaps. Now, if we note that shortened life expectancy and intellectual disability alone, by screening for only the 5 currently recommended conditions in Ashkenazi and Jewish populations alone, 87% of affected pregnancies are missed. Think about that, 87%. And so we currently recommend through ACOG, my organization, cystic fibrosis, Tay-Sachs, dysautonomia, Canavans, and spinal muscular atrophy in this population. But even with that, 87% of affected pregnancies are missed. If we take it one step further and talk about X-linked conditions for the current guidelines, do not currently even specify to consider X-linked conditions for inclusion in the pan-ethnic panel. Think about Duchenne's muscular dystrophy. Alpha thalassemia, X-linked conditions represent 67% of inheritable risk in the African American population. Think about that. And when we begin to talk about things like Fragile X, which we'll talk about at the end of this, we can have a lot more thought around those types of things. Now, pan-ethnic screening, current guidelines, if we suggested a 20-panel, condition panel, look at what this goes up to. If we take this up to a 38-condition panel, look at what happens in African Americans, Ashkenazi Jews. U.S. weighted population goes from 36% on the bottom to 89% in then 38-panel sequence. East Asians, South Asians, Native Americans. Look what happens in Native Americans, 28% to 81%. Very, very different parameters when we begin to think about pan-ethnic screening. So what should a core panel look like? And this core panel really is put together just thinking about some conditions that you may not even think about every day. And I've seen over my 30 years a lot of these situations to occur, and I've taken care of patients with it. 21-hydroxylase deficiency, very important because it causes it's an autosomal condition that results in androgenization of a female fetus in utero. Alpha thalassemia, very common in the Asian world. Canavan's disease, we've already talked about. But if you talk about a core panel of conditions that have a carrier frequency of 1 in 100 or greater in the ethnicity, this is just a small group of those, a small group. Additional screening also may be indicated based on a family history. And we can talk about that as well because I've taken care of a lot of pregnancies affected by Krabbe's disease, which is a very, very profound debilitating condition in youth. And we can show you a little information on that. So Sanger sequencing, it was introduced, is available technology, contribute significantly to the lag in carrier screening protocols, and really the gap in carrier frequency data across population was impacted carrier screening protocols. So this technology was first developed in the 70s. It enabled the assembly of the first human genome. You can see the turnaround time for single gene analysis depending on the size of the gene in question, and so forth and so on. We evolved this a little further when we take it from Sanger to the next generation sequencing, because next generation elevated even more. It was about an ability to confidently identify the difference between a patient's genome and the reference genome. And such genomic differences called variants fall into two classes. Changes to the DNA sequence called SNPs, or short insertions and deletions, indels, large deletions and duplications. When you take next generation and Sanger sequencing, both repurpose DNA replication machinery. But next generation does so in a way that is more scalable and results in a digital output versus an analog output of Sanger sequencing. Again, massive evolution. And I don't want you to try to concentrate what is on the right of the slide. The summary really tells you what we want to show. And again, this is published in Current Genetics, and you'll have this for your review if you choose to go that far. I have used DNA microarray quite a bit. Very, very important for stillbirths and for miscarriages. DNA microarray measures expression levels of large number of genes simultaneously or to genotype multiple regions of a genome. So again, just another expansion of the genetic capability of helping you to make a diagnosis. Microanalysis techniques are used in interpreting data generated from experiments on DNA, RNA, protein microarray. Very, very common in the cancer world today. And this is what we're going to talk about when we talk about gene therapy and how we can get to gene therapies to treat certain cancers. Taking a piece of tissue and doing this gives you a target that you can counter with various therapies. So we're coming down to a summary here. Expanded carrier screening technology has shown advancement in the screening of genes. Next generation sequences is performed to examine multiple genes at once to identify copy number variants and pathogenic or likely pathogenic duplications and deletions of 2 or more exons in length. It's a lot of genetics mumbo jumbo, but let's just say you're getting more from your tests. Single exon pathogenic and likely pathogenic copy number variants will also be reported when detected. And again, long-range polymerase chain reaction captures functional genes for accurate analysis of genes with known pseudogenes. And multiplex ligation-dependent probe amplification detects, again, copy number changes for disorders. I've mentioned some of those disorders already. Congenital adrenal hyperplasia, Gaucher's disease, spinal muscular atrophy, alpha thalassemia. And think about Duchenne's, Fragile X. Fragile X is associated with GCGG repeat analysis. Why is this important? Because over generations, the more repeats you have, the greater the risk for intellectual impairment, the greater the risk also for adult manifestations of Fragile X beyond just intellectual disability. Expanded carrier screening technology, PCR amplification, genotypic analysis to identify and confirm variants, Tay-Sachs enzyme testing as a biochemical analysis to use to detect carriers of Tay-Sachs disease that may be missed by molecular testing. I'll show you an example of that was actually from the New York Times. Sanger sequencing, exon array, all of these type of things are the advances in the technology in screening for genes. So, what does a panel give you? It allows carrier screening across a broad range of inheritable conditions. It increases carrier detection rates regardless of ancestry. It identifies pathogenic variants of 100 plus of genes and variants of known, and let's face it, unknown significance. Because the more genes you screen for, the more things you might find that you really can't explain. Some of them may be pathogenic, some of them may be non-pathogenic. But identifying pathogenic variants in hundreds of genes has relevance when you go back to what we were initially talking about, that 80+% of abnormalities, intellectual inability, comparatively, come from genetic disorders. It allows amplicons that cover coding sequence regions of a targeted gene. You know, I think about my early genetics world when I could only look at the chromosome. I couldn't look inside the chromosome. And when I would get a panel back from a person, a karyotype, all I could see were the number of chromosomes. I couldn't look inside those chromosomes. And I think that's where we're talking about when we talk about next generation sequences. So here's the sisters that I talked about. And this was in the New York Times, I guess maybe about a month or so ago, and I'm plugged to it on a Sunday morning. And they were talking about their foundation because they were diagnosed with late onset Tay-Sachs. And they asked the question, do you know what it is? And so basically, how did they find out? In 2014, genomic sequencing informed us that they were late onset Tay-Sachs screeners. They were having symptoms in their adult life, not picked up on the standard molecular screening when they were born or later. And you can see where we're talking about going with this. Very important for them when they decide to have children or if they decide to have children. I want to talk about Fragile X because it's one of the more complex disorders that I've dealt with, particularly in the preconception world, because it affects men and women. It's a neurodevelopment disorder characterized by an expansion to 200 or more repetitions in the CGG sequence of nucleotides. And that's basically what it is. Individuals who have 55 to 200 repeats are said to carry the permutation. A fewer mutation gene is the leading inheritable cause of intellectual disability. And so let's go back to a family history. And how to take a family history today, because I've dealt in the Fragile X world, is a little different than I would have taken it years ago, because I'm going to ask about, is anybody in your family, and keep in mind I'm from the South a little bit, has been told to be a little bit slow or being classified as intellectually, and they say, oh yeah, Uncle Joe, has always been a little slow, and his son is a little bit slow, or his daughter's also a little bit slow, and you begin to kind of pick this up. And the first thing that pops in my head is, oh my gosh, they have Fragile X. Now, it may not be that they have Fragile X, but it's certainly the thing that I'm going to test for, because it talks about women and men who have evolving intellectual disability. And it occurs in about 1 in 3,600 individuals in the general population. So you would think that we'd want to test for it because of what I said here. It is one of the leading inheritable causes of intellectual disability. I'm going to get off my soapbox about that now. Children and adults with Fragile X syndrome have heightened rates of co-occurring mental health problems, and it affects males and females. Very, very important for us to keep in mind. Information empowers families. So this is a case, for instance, and I've sanitized this to some degree. It talks about an autosomal recessive disorder called Wilson's disease. On Christmas Day in 2015, their oldest daughter, age 12, suddenly began to show signs of liver failure. She was admitted to the hospital, experienced numerous complications before passing away on January 19, 2016. And these are the kind of stories we collect. The complications and advanced liver and kidney failure led to her death, and posthumously she was diagnosed with Wilson's disease, confirmed after her death. After her death and the diagnosis, her 3 younger siblings were all tested. Her 9-year-old sister and her 7-year-old brother were also diagnosed with Wilson's disease. Keep in mind, it has a 25% chance of occurring in each pregnancy. They're undergoing chelation therapy and are doing well. So Wilson's disease is one of those autosomal recessive with a carrier frequency of around 1 in 100 in at least 6 ethnicities. This is why this case is so important. A result of an inborn error of copper metabolism. And these infants and children and adults have to have a lifelong dietary changes and medications to keep them to avoid severe liver symptoms and liver failure. Current carrier screening guidelines introduce inconsistencies in fetal risk assessment. And we're coming to the end. Only cystic fibrosis and SMA are recommended for pan-ethnic screening. Additional screens are recommended for selected ethnicities. Expanded carrier screening is an acceptable strategy for screening all patients. And think about the fragmentation of care and the cost of care and the rural access to care, all of these type of things that really impact a woman and a couple's inability to screen for their entire risk. And if they only use certain panels or even family history alone, it has significant limitations. It recommends pan-ethnic screening for all, clarify the 1 in 100 criteria to be 1 in 100 in at least any ethnicity. This is what we want to happen. And, of course, include X-linked conditions to provide a comprehensive fetal genetic risk. In summary, expanded carrier screening uses next-generation sequencing to evaluate a wide range of genes implicated in inherited disorders, allows for a better assessment of carrier status in a growing multi-ethnic society, and geographic population distribution, and allows for more thorough risk assessment for counseling in couples at preconception, which I do in the world I live in reproductive endocrinology and MFM, and in early pregnancies, including pre-implantation genetics implications, which you certainly haven't gotten into in this discussion, which will be a topic for another time. So with that, I'd like to thank you.
We will now move into the Q&A. Our first question is, what is the best possible way to design a gene panel for NGS for a genetically heterogeneous condition such as deafness?
Oh, very interesting. Deafness, keep in mind the leading cause of congenital deafness in the United States is actually cytomegalovirus. but there are a number of conditions that are associated with deafness that occur as a result of one of the signs and symptoms of some of these disorders. But if you were taking a broad category like that, your bang for your bucks would be in screening for, not through these panels, but to screen for, CMV, for instance. So I can't answer the question that way, because if you look at there are some conditions that are associated with deafness, but many that are not.
Well, I can add a little bit. So that is definitely one of the more challenging conditions to design. Us at Thermo Fisher, we have invested heavily in the AmpliSeq technologies and the know-how. So to help ease some of the burdens there, in our CareSeq panels, we actually have 8 genes covering vast majority of the deafness genes, including one of them with the CMV target. So if you're looking to overcome those challenges, you may want to speak to one of our colleagues to able to share that with you.
Great, thank you both. Our next question is, can carrier screening be done using an exome panel, which is actually intended as an NGS panel for screening patients with currently unidentified causative mutations?
George, you may want to take that one. The short answer is,
can you repeat that again?
Yes, I can repeat the question.
Yes.
Can carrier screening be done using an exome panel, which is actually intended as an NGS panel for screening patients with currently unidentified causative mutation?
Thank you. In a way, you can. However, there are limitations in the exome panel where a lot of the single copy deletions are going to be very challenging to be picked up. So if you do go down the exome panel path, you will have run into a lot of the conditions and a lot of the variants mutations that the panels or the technology simply has limitations that would not be able to address.
And I would add to that, they may be pathogenic or they may be non-pathogenic, and we won't necessarily know what they mean. And so, short answer, complicated, yes, and then a lot of questions.
Right. So you also have, therefore, add to Dr. Brown's answers, are you prepared to report variants of unknown significance, which then also creates another level of complexity of how to counsel patients based on those findings.
Okay, great. Our next question is for Dr. Brown. At what gestational age should a pregnant woman be tested for genetic factors?
As soon as possible. And so if she presents at 4 weeks, 5 weeks, 6 weeks, you want to offer a pan-ethnic genetic screen at that time. You certainly can, if we were to do just the standard things that are currently on the books for ACOG and genetics, we would do those things because that may be what her carrier pays for. Our thoughts are, if she's appropriately counseled, even after you take your basic family history, that can be done early. It's not like when you're trying to do non-invasive prenatal screening for aneuploidy where you have to be at a certain gestational age. Ideally, these panels should be done preconceptionally in couples. And the only group that we get an opportunity to do that with are the persons who are coming in who are looking for in vitro technology. And so that becomes even more important in that group of patients that we screen them before they even undergo IVF and embryo transfer.
Great. Our next question is, how would you propose handling variants of unknown significance detected by NGS technology?
I think that was kind of the thing that George and I were alluding to earlier. You're going to get some things that you really don't know how to interpret. Variants. What do they mean? It may mean that I'll give you an example. There are probably variants that would tell us whether we are going to be destined to develop Alzheimer's. we don't really know how many variants there are like that, something that may occur later in life, but is not really linked to any particular syndrome or any particular autosomal or X-linked or autosomal dominant disorder. And so how we handle that is to say, quite honestly, we say, we found this, but we're not quite sure what it means. We don't have a syndrome that it's been linked to. We don't have a genetic disorder that it's linked to. It may mean that you are at risk for something because it's a variant. And so that's really the way we would answer that question.
Okay, great. The next question is, how do you decide which panels to offer?
Let me just say that panels offer different things in terms of how many genes that they will actually be able to go after. There are some panels that go after as many as 900 different genes, certain panels that go after 400 genes, certain panels that go after 250 genes. What I've tried to show you in my slide is when we begin to think about the more common disorders that really will be impacted by at least 1 in 100 in any ethnicity, that number may be 100 that we need to deal with. And so the idea, do we get more and really not know how to interpret it, or do we get somewhere in between? And so I would say that a panel that at least offers what we're talking about with at least 1 in 100 in any ethnicity would capture, as I've going to show you, at least 38 more conditions, or maybe as many as 75 additional conditions based on that panel.
Great. Next question is, what are your thoughts on creating a carrier screening panel that matches the state's newborn screening panel?
Very interesting question. The newborn screening panel currently doesn't screen for that many things. So when I talk to my pediatric genetic colleagues, and we've had this conversation recently, they want to expand the newborn screening panel to include more conditions. They've talked to us about this because the key is prevention. Once you're screening for a child who has already the condition, we're talking about screening at the earliest level that we can so we could get perhaps into more advanced treatments. It's something about knowing that you're going to have a child with a particular autosomal recessive disorder that then could potentially benefit from the therapy and decrease the morbidity and mortality associated with many of these conditions. And so while I'm for the expanded newborn screening panel, they would literally have to expand it to 10 to 15 more things as opposed to us screening a couple for 30 to 40 to 50 more things. Again, earlier the better, so that we could talk about how we can treat and intervene. And I think about this because so much advances now in gene therapy. One example of Krabbe's disease I would tell you about, a couple has a child with Krabbe's disease, the baby dies. She gets pregnant with another child. That child is now a candidate for cord blood transplant. We're doing that with sickle cell disease. We're doing it with Tay-Sachs disease. We're doing it with so many conditions. And there are major evolutions going on right now with alpha thalassemia. And so, again, that's where we want to talk about going with this. I thank you for the question, though.
Great. Our next question is a follow-up to the previous one. What do you mean 1 in 100 in all ethnicities?
At least 1 in 100 in any ethnicity. So when you go back to my slide that looks at what would change if we just did ethnic-based screening, what I've shown you is how we can go to almost 100% from, say, 27% in Hispanics, because people have mixed heritage, mixed ethnicity, and so forth and so on. That's what I mean by that. So any ethnicity would bring you so much more for any condition that has at least that 1 in 100 gene frequency.
Do you know if any state is planning a recommendation for ECS?
Actually, there are a lot of, from a statewide perspective, but there are a lot of, the states really have not, that's very complicated because it really is what you counsel patients for as opposed to what's mandated that you count, that people screen people for. No state has mandated that you do this. And I think you're thinking back to California in the early days of NIPT screening. And so, yes, they said it wasn't mandated, but it was that you would offer it and they would pay for it. And so what we're now saying is that offering it and getting it paid for based on our counseling and our shared decision-making with our couples is really what we have to do. And so the more providers we educate, but also many of the family foundation groups are the biggest pushers for expanded carrier screening.
What's your opinion on how many genes or conditions should be included in an expanded carrier screening, and what would be the inclusion criteria?
So I go back to my slide that I showed you of about 38 to 40 conditions that would automatically show up on a panel if we did pan-ethnic screening based on 1 in 100. If we were to do that even further, we could get up to potentially 100 conditions and so forth. So I say at a minimum, those 50 more common conditions that I listed on that slide that will reflect that.
Great. Next question. In your view, should we be screening every pregnancy for as many genes as possible, or do you advise a more targeted approach based on family history or ethnicity?
I think we need to screen a couple based on what we said for as many conditions as we can that are known to exist to be pathologic and some non-pathologic. And so the answer is yes. Rather than doing family history or ethnic-based screening, we ought to look more broadly into how we screen a couple for a condition, again, inheritable conditions that affect life expectancy as well as intellectual abilities.
Great. And do you think offering ECS patients should start at the family practice level?
I'm not sure what that means, except you're talking about what specialists they ought to see. I think that
I guess if they're...
Is that what they're referring to?
I think so, yeah. They're asking if it should start at the primary care level.
Whomever your person that you're seeing, ideally, every woman of reproductive age who's at risk for getting pregnant, like folic acid, ought to have that discussion about that family history when they go into the doctor's office and when you go into your practitioner's office. And let's say that you are going in to have your blood pressure checked, or you're going there and you say, well, I'm thinking about getting pregnant. And you look at the family history, and the family history says, there are 3 people in my family, immediate family, who have intellectual disability. There are my aunt had breast cancer. My sister's husband's brother had a child with cystic fibrosis. That's kind of the history you get. Then you have to go from there. You have to have an aha moment and say, yes, but we do know that in a 15-minute visit, this does not do that justice. And so you got to know when to go further and when not to go further. So I would say whoever that provider is, regardless of the setting. Since most people go to their OBGYN or women's health nurse practitioner for their routine care, that is the place to start. And if that happens to be a family physician in the state of Washington, where a lot of family docs do prenatal, pediatric, and so forth and so on, all the better.
Great. Next question. Can this expanded carrier screening be used in Asia? And do you have enough disease information in Asia? Also, how often do you update mutation sequence?
Well, keep in mind that these are now pretty widely distributed. So depending on which one you use, I would tell you already you're looking at anywhere from 250 to 500, and some panels offer up to 900 different genes. That may be more than you need. But to get back to one of the things I presented is geographical. And I'll use an example. When I was at Duke, I did spend a lot of time in Singapore. Well, Singapore really is a very, very ethnically diverse country when you think about Asia, Malaysia, et cetera, et cetera. And Indians who are there. And so when you think about also that 25% of the population are expats, of course, this should be the standard of care geographically. Even though the population per se may be more Asian, it would like be saying that we should only offer certain types of things in Africa. And we know that's not the case, because Africa is very different. If you go up to Morocco, where you're also very close to the Middle East, there's a lot of different ethnicity there when you think about it. So the answer is yes. We need to think about this globally.